So good morning, everybody. I'm Barbara DeGraff, and I work with Strategies Technical Assistance. And it's really my pleasure to support Danielle Lowe and Christina Ramirez from Shields for Families in this second of their two workshops today. And this one is on building community pathways, collaborative school-based mental health for BIPOC youth, Black, Indigenous, people of color youth. And we'll welcome you all here, and we hope that we can be interactive. We only have 31 folks, so if you want to ask a question, feel free to raise your hand and we'll call on you. And we hope that you have a lot of questions because they have some great programs. Go ahead, Danielle and Christina, take it away.
Perfect. Okay. Well, hello. Thank you for that wonderful introduction. Hopefully you guys were able to eat. If not, we hope to entertain you enough to stay awake. I am Danielle Lowe. I'm the Behavioral Health Services Director at Shields for Families. I have been fortunate to be with the agency for 22 years, so been able to see a lot of growth and be a part of this growth, especially some of the growth we'll be talking about today. I am an Inglewood, born and raised native, so LA County over here, but also definitely shared growing up in Leimert Park as well, if you're familiar with the community. And I am a mother, and I identify as biracial. I am Black and white. And so just sharing that, because for us, intersex and culture definitely play a part in our services and why our model is the way that it is. And so we definitely think it's important to highlight just some aspects of who we are.
I'm Christina Ramirez. I'm the administrator in our behavioral health services. I've been with Shields for about 10 years. Thank you all for having us. I also am an LA native, also from Inglewood, so we are representing hard right now. I am a mother, a wife. I have two girls, a 3-year-old and a 1-year-old, and a new puppy, so my life is just always wild. But welcome. Thank you all for coming. I identify as white. I do have 2 biracial children. And again, just we appreciate you all for being here and hope that we can have a great conversation. Today, we are going to be talking about race. We're going to be talking about systemic discrimination in the education system and across systems. We'll be talking about disproportionality. So really just listening to your body. If you do feel that you're triggered, feel free to turn your camera off and take some time. You can also private message us and we can provide some support. Trying on the perspective of the person speaking. We all come from many different perspectives in this room. We're talking with Barb, and there's a little bit, she's from rural counties and we're in a big city. So just so many different perspectives shared. It is okay to disagree, not okay to blame. If you do disagree, please come off mute and let's talk about it. We would love that. Practice both and thinking, avoiding either or, leaning into any of that discomfort that you might feel, and then really acknowledging intention versus impact. We're all here because we value prevention. And so really, if we misspeak, our apologies ahead of time, but we all understand we're all here for the same purpose. Just some housekeeping rules, I guess. Danielle and I we're very in-person people, and so we appreciate if you just come off mute or interrupt us if you have a question. We're very open to that.
Perfect. Thank you. And so just some of our objectives in an overall sense. Number one, really just to understand the impact of systematic barriers on youth. We are talking about all youth when we are doing this presentation. However, we will highlight throughout this presentation African American and Indigenous youth because they are still so disproportionately represented in so many systems, whether that be child welfare system, criminal justice system, and then overall rates, specifically regarding graduation and disciplinary action. And so our motto and philosophy, as many of you in this shared space, is really if you address it for those that are most marginalized, then the system will definitely support all of those that are a part of it. Our second one is really focusing on school connectedness. And so that's really us taking a look at the inclusion of culture and trauma as it relates to our youth and our families and our community as they're navigating the academic setting, and how that impacts overall behavior and then just the outcomes that we see within academic settings. And then for us, while we'll review some interventions that we utilize within the school setting, we will be focusing on MST and FFT, our evidence-based practice models that we have now moved within to 2 schools, more than that, but really focusing on 2 of our schools and the work that we're doing there to really support the community and engaging families through the FFPSA Community Pathways model. And then some key terms. And so family-centered treatment, that is our model and our lens at Shields for Families. So really focusing on the entire family. While an individual may come to us, we really focus on everyone that supports them within that system. What's unique about us is that family is anyone that the participant identifies as family. So whether that's a pastor, basketball coach, soccer coach, whoever it is that they identify as family, if they are a support, we include them as part of their treatment in order for them to meet those goals that they've identified as a family. Cultural humility, incorporating culture, understanding culture, but most importantly, being that lifelong learner, understanding that we never know everything about anyone's culture. And so being open to learning from our participant, they are the expert of their lives. And so us being able to put on that learner hat and sit in that learner position so we can continuously adapt, evolve, and ensure that we're providing quality care and services to our families. And then BIPOC, standing for Black, Indigenous, and people of color. We will use that in and out just to cover group, but just so we're all on the same page. And then we are going to give you guys a little bit about it. So Shields for Families, we are located in SPA 6, and so that is South LA communities within LA County. And so we really started off in response to the crack epidemic that hit the South LA community. At that time, when drugs really entered into our community, the policies and the thoughts were war on drugs, they're criminals, we need to take children away to protect them. And so what we really saw was families being dismantled either through the criminal justice system or the child welfare system. And so these 3 amazing women started Shields for Families, our first program being Genesis. And so the ideal around it was to really provide a one-stop shop family system support to address substance use and all of those other aspects of life that come into play when you're dealing and navigating your sobriety journey. And so in 1990, we started. In 91, we were officially founded. And from then on, we have been actively serving the South LA community since 91.
And we use a family-centered treatment model. It really started in our Genesis program as the core service that we are providing, is we're providing services to the whole family. And it was different from the traditional treatment model where a mother was really forced to choose between treatment or staying with their children, especially if she had, let's say, a 12-year-old male son. She had to pick between, oh, do I get to involved in this program or do I get to stay with my son? And so our Genesis program was developed to just say, bring everyone, bring whoever you need to involve in your treatment, and let's really work with the entire family through this. Through that model of family-centered treatment, we have about a 70 to 80% success rate. The national average is only 25%. So we really do just see that the family-centered treatment model is essential in substance abuse, in mental health treatment, in any of the services that we're going to provide. It's crucial. And so as Danielle said, it's just whoever they want to identify as their family, that's who we're going to include. And then just making sure that every single member is a part of the case planning and the decisions about what their goals are and how we can help to support them in reaching those goals. Some of the core components are just the overall integration of services. So we know across systems, we have not made it easy for families to access the help that they need. And so at Shields, we want to make sure that it feels like a very seamless approach. So it's really a one-stop shop model where we collaborate as professionals across programs to make sure the family just feels like it's one stop. I don't have to go anywhere. I get everything that I need in one place. All of our services have a culturally integrated model. So we're in the community. Our community voice is very, very important in informing our services. And it's just essential in how we choose what funding to pursue, what services to expand on. That's just crucial in that. And then we're located within the community and always with a collaborative approach with our partners and with our families to make sure that the services we're providing are the ones that they want and that will help get them closer to their goals.
So the data, we've come to love data, y'all. If you knew us before, you would say we're like, statistics. Why did I have to take that to pass my master's program? But we definitely see why now. And so really for us, the data is really giving us that overall look of the why we are doing what we're doing. And also really looking at the historical components that impact what we're dealing with today. And so for us, in regards to educational system, there is no way that we can approach change and or address change within our school systems if we do not look at the historical context, especially related to a lot of the schools that we provide services to within our community. So historically, we do still see the direct impacts of Jim Crow laws, Brown versus Board of Education, the SAT and test taking, and again, in those policies related to taxes. So within our communities, our public school education is dependent on property taxes. So when you look at communities that are really owned by the government and or in lower socioeconomic status areas, we definitely see the impact on schooling, the educators that are within the school, the amount of resources within the school, and just really that overall curriculum that is being received by our participants. So for us, it's really important to understand the why and the needs within our community, the needs within our system, in order for us to go in and not just really do this Band-Aid change, but really make a systematic impact on what we're doing so we can see that continuous support built in for our families and students for sure. So if you are not familiar with LA County, we are large. So LA County has 10 million people within it residing. Within SPA 6, which is the community that we service, we have 1 million of individuals within the community. There are some demographics here, but some I want to highlight are really our age, because we have a younger population in comparison to other counties. So about 23% of our county is 0 to 17. 64% is at 18 to 64 age range, and then 11% is 65 plus. And so that really does shift and allows us to see who and where we need to target, who we need to support, what interventions, and how we need to approach those interventions within our community by having that breakdown. Also, another key highlight for our demographics is that within LA County, about 7% of the population is African American, but within SPA 6, 30% of the population is African American. So there is a large population of African American individuals within the SPA 6 community. And so again, this is part of why we will highlight services tailored to African American families in conjunction with that disproportionality that we're seeing.
And with that disproportionality, just African Americans are overrepresented in the criminal justice system, disproportionately represented in the child welfare system, and then less likely to engage in behavioral health services due to the historical and systemic oppression that's been experienced. Our behavioral health system is no different. 2018, SAMHSA conducted a national survey that said 16% of African Americans report having a mental illness. 22.4% of those reported serious mental illness. And then in 2019, suicide was the second leading cause of death for that TAY population. African Americans through this survey identified barriers to include stigma, distrust of healthcare systems, lack of providers from diverse backgrounds, lack of culturally competent providers, lack of insurance or underinsurance as barriers to treatment. So we have excuse me, we have a lot of work that we need to do in the behavioral health system. This graph shows that throughout the years, major depressive episodes continue to increase for African Americans across the ages each year. And so we see this increased need that's really approaching the national average. But at the same time, we see a lack of involvement in treatment. And this information really does show that our services have not been designed and set up to include African Americans and to include a population that's continuously showing over time there's an increased need. And so this tells us we need to approach our behavioral health services much differently so that we can include a population that's really being missed. You can see 88.7% of youth with a substance use disorder that identify as African American are not receiving treatment. And same thing for co-occurring disorders. For adults, 91% are not receiving treatment.
So continuing on with this disproportionality that we're seeing, some of the areas we want to highlight is that disciplinary action that we see within African American youth. So 84% see or experience an out of school suspension in comparison to 24% across LA County. So we see that the disciplinary action or reaction that our African American students are facing is dramatically different from their counterparts. And so for sure, this is something within the system that we need to address because there are embedded biases when it comes to African American students, which ultimately impact graduation rate, that we see within our communities because of the constant being out of school. Then getting behind on work and or not receiving services are unfortunately being grouped as a bad student, a bad kid. They don't want to learn. And so then the biases continue within the support staff or the individuals that should be support staff. The student is unfortunately labeled and then treated in a manner that does not usually provide successful outcomes for them. And so next, we really want to highlight that school connectedness, that our youth don't necessarily feel a sense of connectedness because of a lack of understanding culture, a lack of understanding trauma and the impact of trauma within the community. So what can we do as a system to ensure that our students feel represented, that they feel heard, and that they feel a part of the system that they have to be in for 18 years, maybe less, 15 years of their life, ultimately more if they go to higher education. And then also we see this increase in SI and SA as suicide ideation and suicide attempts within African American youth. And so we want to make sure that, again, those mental health supports are being embedded within the school system, whether that means having mental health staff on site and also supporting educators with identifying those symptoms and behaviors that are indicating mental health supports are needed, right? So sometimes that wearing of the hood is not to be defined, is to hide from something, to hide from people, and to be a little fearful or saying that I need a little bit more support, but through their body versus their words. Sorry about that, y'all. I tell you, I'm running on caffeine, but we're gonna get through this together.
We have a question in the chat.
Yes.
I just wanted to point out. So is it Deise who asks, please correct me if I'm mispronouncing, is there a youth diversion program or programs in LA County that instead of placing youth on probation, they are referred to specific services, behavioral health and or substance use treatments?
Good question. We do work with a one diversion program that's located in Inglewood. They definitely support the youth with that diversion process. In general, that is the one that we do work with. I will say that we can explore more. That is the only one I know of right now. Christina, you can jump in. If not, what we do have though is a relationship with probation. And so probation definitely sends us referrals directly. And I know that's kind of after the fact for sure, but definitely they're open to mental health supports. I will say that.
Mm-hmm. Yeah, we definitely see the referrals from probation for that. Compton Unified has a pilot that is the diversion program that Danielle's mentioning. They're based out of Inglewood, but they also do a Compton Unified diversion program. So the model is, instead of disciplinary action, they do like restorative circles in the schools, and then we partner after the fact. So they do the restorative circles, and then we provide mental health if there's like a continuous ongoing need for them. That one is Sentinella Youth Services that does the diversion program. Great question. I definitely think it's an increased need in our area, though.
Mm-hmm.
So with that, we're actually kind of talking about that perfectly leading into this, but the school to prison pipeline, and just understanding that diversion is so important, because we're seeing that Black students are suspended at much higher rates. And that school to prison pipeline really does start. We're seeing even researchers showing now in preschool. And so 51% of white students are enrolled. For white students, they represent 41% of students referred to law enforcement and 39% of arrests. However, for Black students, they only represent 16% of students enrolled, but 27% of students referred to law enforcement and 31 subjected to arrest. I know Danielle and I in our work, we've seen as young as a 5-year-old that gets arrested at a school. And so it really is starting very young, and that's where we want to provide the intervention. This study was done, it's called The Essence of Innocence, but the 3 hypotheses really were that Black boys were seen as less childlike than their white peers, and that the characteristics of childhood wouldn't be applied to Black boys as often as white boys, and that the trends would be exacerbated in contexts where Black males are dehumanized in association testing. All of those hypotheses were founded in this study. So basically, how that applies to the school is that if 2 students were caught pushing each other on the field, a white peer would have the benefit of like, oh, they're just children, they're navigating their bodies, they're learning conflict resolution. Whereas Black students would be, they're defiant, they need punishment, and they are disruptive or whatever. So they don't receive the benefit of the childhood and the childlike as much as their white peers. This resulted in just Black boys seen as older and less innocent, according to this study. And then they tested law enforcement with association testing. So the stronger your association with Black males to apes, the more likely you were to use violence against race in your police intervention. And so the association was very, very strong with there.
Thank you, Christina. And then ACEs, I think if you were able to join the opening presentation today, we really all were provided with a great overview of the impact of ACEs. And so for us, this is something that's really important. And again, a lot of these slides that we're presenting to you all, we actually present to educators in training. So they're aware of the community and who they're servicing. And so ACEs, as we know, is a great indicator of how much work we need to do, how much support we need to provide to our youth. And so really schools is that place that we can do that, because they all have to go there, and they're there for a long time throughout the day. And so for us, it's really important. ACEs is important in the sense that we don't necessarily just calculate the number, right? For us, if you have 1 ACE, you need support services. It's really important to look at what that ACE is, how it's impacted you, and then creating the support plan. And we can go to the next one. So as we know, 50% of all children have at least 1 ACE score. And the impact on education, we see this increase in failing grades, lower performance on those standardized tests. Couple that with the historical aspect of what standardized tests were made and designed to make African Americans seem less intelligent. So coupled with some of those historical factors, we just see this continued pattern of quote unquote unsuccessful outcomes and or low performance within African American communities. We see difficulty with language. And so whether that's the inability, like that one child that I brought up earlier and stumbled over, but that has their hood on within the classroom, their inability to communicate their emotions and their feelings and their need for supports, right? So we see that impact and kind of going into that freeze response and not being able to ask, or that fight response when they're quote unquote defiant. And so we see those language difficulties coming up, those being suspended and are expelled. Usually a higher enrollment in IEP 504, so those specialized educational programs, and then those social determinants of health. So because of those systematic mistrust, because of those historical contexts that we reviewed, really not engaging in preventative health care overall, and or because of a mental health diagnosis that is not being cared for, we see people not engaging in other supports to support their overall health. Okay, so what do we see with child welfare systems? So why we're all here, and we probably all know this, that usually our youth are coming into contact with the child welfare system either through labor and delivery, really that 0 to 5 age range, and or because of a report that is often made by educational staff. Now, we are not attacking educators. We love our educators. What we've come to find out with training and our partnerships within our communities is usually educators are told, just call, just call. And so our educators are really trying to find supports for the students, but unfortunately, it can sometimes lead into unnecessary involvement into the child welfare system. And so this has also caused, of course, a systematic trauma within both the schools and the child welfare system. And so what can often be perceived as resistance is really a very understandable reason to have mistrust in both the educational and child welfare, welfare system. One of the key things that we want to point out here is that within the African American and Indigenous community, there is a 50% chance by the time an individual reaches the age of 18 that they will have some connection or touch from the child welfare system. So once again, really just confirming why there is a mistrust with education and with child welfare system, because unfortunately, the likelihood of becoming unnecessarily involved is a really real statistic based on our current data in California. This is just going over our current child welfare. Well, this was as of 2022. So really just highlighting the slide to my right. I think that's everybody's right, but to the right, just the cause within the educational system. So really focusing on ones that are actually substantiated. So if you see with education, there's about 24,000 calls made, but only 6% of those calls were actually substantiated. So this data really shows us that a lot of families can benefit from preventative supports instead of child welfare involvement. And so a lot of our work that we do is really to go into the schools to provide that added support to ensure that those families that don't need to be a part of the system never make contact with those systems, that they're actually provided with support plans, nice warm handoffs to ensure that they get those wraparound preventative services and aren't linked to child welfare system unnecessarily. So our call to action, Shields for Families. What do we do, Christina?
So the first thing, so we started with that one treatment site that was doing the family-centered treatment, and then just expanded into understanding, okay, we're providing substance use treatment, but we really need to support in the mental health component for the families across the lifespan. And so at Shields, we got our DMH contract in 1997, and just to support with community mental health needs. We had built the relationship with community members and now really needed to show that you can provide culturally responsive mental health services and work very hard to destigmatize mental health within the community. So that was mid to late 90s. And then now we have services just across the entire lifespan. Um, and they range from substance use treatment. So we have substance use services for ages 12 and up. We have adolescent, perinatal, and then our co-ed facility. We have a group of clinicians that are specialized in birth to 5 mental health services, really focusing on attachment and repairing relationships where attachment was ruptured. Children's mental health is for 6 to 20. Our family mental health program, we will talk more about, but they provide MST and FFT services, really evidence-based models for family mental health, ensuring that we're strengthening the family. Adult mental health is for 21 and up. And then assisted outpatient treatment, those are for seriously mentally ill individuals in an outpatient model. The psychiatric services, we have a child and an adult psychiatrist who have roots in the community and just do amazing work with our population. We have CalHope, and then our TAPE programming focuses on 18 to 30, focusing on that big transition in life, preparing with housing supports and vocational services, understanding that in our spa, that is a large chunk of our population within that age range. And then just additional community supports, reentry services, vocational and educational services, and all of that. This is kind of our journey into where we are now. We started, like I mentioned, with that one substance use program and then just grew from there. Our Heroes and Sheroes program started as an after-school program for the children who their parents were receiving treatment for us. So that parents could focus on their treatment and the children were getting interventions at the same time. So we would pick kids up from school, bring them over, have after school program where they would receive homework help and then groups for really that preventative work. They talked about conflict resolution, healthy coping skills, drugs and alcohol, all of that to really prevent that cycle in the family. And then from that, we really noticed, wow, these kids need a lot of support in the schools because the schools are not being responsive in a way that they need to be to the children that we were seeing. And so we would be in the schools, mostly it started with Compton Unified, and just working with teachers on how to address that specific individual, things that would trigger the individual, and ways to help them self-regulate in the classroom so that they can be successful. And then it was a lot of word of mouth and to grow into different schools. A lot of like, oh, this school really needs support. And so we would go over there and then it just expanded into many partnerships throughout our South LA community. And within those partnerships where we can have evidence-based interventions, that's really been our largest area for growth recently, is just being able to provide quality care to all the families who have students at our school partnerships. So now we are in 80 different schools, over 80 actually, and then we focus districts, we focus on Compton Unified, Inglewood Unified, Paramount, and LA Unified. And then we have charter schools throughout the South LA community, and also newly, we have 6 Catholic schools that we partner with to provide the mental health services on site. All of our services there are outpatient and they're field-based. We do love going into people's homes, so if they allow us, we will also be in their homes too. So it's not just school-based intervention. And then with those partnerships, we offer mandated reporter to community supporter training to just, we see the demographics that educators are the largest reporters to child welfare. And so that's the biggest opportunity for us to provide training. Many educators, the vast majority that we come into contact with, they see an issue with a kid and they've been told that child welfare helps, and so they just call. And so we want to give them other alternatives to calling. And that really is where that partnership is formed, where we can say, no, there's all these community-based organizations. We're one of them, but there's plenty others as well that can really help to provide supports without the need for child welfare. We also offer a 6-part trauma-informed educational series that helps teachers feel equipped to navigate behaviors that are expressing in the classroom. And so just different ways to approach children and also like ways that encourage safety in the classroom for our clients. And then we also have 3 charter schools that we started with Los Angeles Education Corps. These are schools that we started from the ground up. So we were able to start with the policies and how do we enforce behaviors in a way that's different from the mainstream education system. So for example, if a student is caught with substances on campus, we require that the school provides treatment instead of suspension or expulsion. So those types of policies that really were restorative were embedded in those charter schools. So we have 3 charter schools, Compton, Watts, and Inglewood. And we have 3 therapists and 2 case managers on site at those schools. They really are developed for children who haven't been successful in the traditional academic setting. And so we provide the intervention in hopes that the student can be successful in a setting where they feel safe and they can focus on their education. And they have been successful throughout time.
Perfect. Thank you for that. Okay, so these next 2 we can kind of go through quickly, Christina. But this is so 2 of the evidence-based practices that we are implementing. So we always had FFT and MST services as part of Shield's services, mental health services. However, we also are providing those services under the FFPSA or under FFPSA. And so with FFT, we really see like these 4 changes or 4 stages of change that the clinicians focus on. We can go to MST. MST kind of structured in the same way, but focusing on 5 behavioral changes that we're really working through. So just in a general sense, FFT and MST, we have seen, we are very picky with our EBPs because not everything that glitters is gold for us. And we really want to make sure that we're able to incorporate the community and family culture within the models and evidence-based practices that we do select to implement and train our clinicians in. And so with both of these models, what is great about them is that the family is whatever the family identifies as family. And so if that 17-year-old male has been key in decision-making within the home, we work with that family and their dynamic. These models don't go in to change the family structure. It's really just about implementing healthy boundaries, those communication skills, identifying those behaviors that are negatively impacting the family. And so with both of them, we've been able to see really successful outcomes and overall engagement with our community because it allows their culture and their family to be the voice and the driving force with the model, and just going in to add some extra supports. FFT really focuses on the child first as the identified participant that's engaged in services. So really working on those behavioral aspects with that youth, whereas MST really focuses on the caregiver a lot more. So pulling in the caregiver to really identify their discipline structure, their communication structure, and then of course, looping back in that youth to say like, hey, did they implement this boundary with you? How did you receive that? Did that work? And so really working in hand with all that are involved in the family. These are very intensive models. They're about 6 months, and the clinician can meet with them anywhere, usually about 2 times per week minimum, but up to 5 times per week. Our clinicians are amazing. We have had clinicians that have done mail routes with caregivers to make sure that they can get a session in. So there's no barrier to where we provide a session. We will follow you and go to work with you to provide services. We love to say we are those nosy auntie and uncles that will be in your life, that will annoy you, and then you end up loving us and bringing us food. And so it's really just about being there with the family and providing that support. So right now, also too, these are some of our outcomes. So you see we have really successful outcomes with our families. and including that lack of recidivism that we're seeing with our youth. A lot of these youth are at risk. Most often they are actually involved with the juvenile justice system. So we do see them, okay, maybe they've been a victim of systematic traumas, systematic racism, their own mental health being unmet, and then we're able to really address those things and they no longer are in the system. So definitely have had some successful outcomes with MST and FFT.
We have a question in the
Yes.
chat from Nancy. What % of families engage?
That is a wonderful question. So we have about 85, between 80 and 85% of our families engaged. Usually the impacts of engagement has been with probation. So here's where our systems need to talk to each other. So with probation, they will send us referrals like 30 days prior to the youth being released to show on their case plan and to the judge, like, hey, we have this plan. And so sometimes that 30-day gap can end up with families either going somewhere else, or if they move, or if the sentence was extended for some reason, then we can see a gap there. However, we do stay in communication with probation just to follow up on those referrals to ensure that they are linked back to us, or to someone, I should say.
Jose asks $1 million question. Where do you find your mental health clinicians? That's a tough.
Yeah, no, that is a great question. So we definitely do like the typical, I think what we all do, we post Indeed, LinkedIn, all of those wonderful things, participating in those health fair, job fairs, those college job fairs, or I don't know what they call them, they're recruitment fairs. We do have a large internship program. We have about 40 interns per year or throughout the year. And so a lot of the times our interns end up becoming our staff. It's because they're getting exposed to community-based practices. They are learning DMH contract, which is a doozy. They are learning the substance use contract, which is also a doozy. And so they're already being exposed to that documentation, paperwork, incorporation of culture. And so a lot of the times we're able to find individuals who represent the community, understand the community, and are open to incorporation of culture within that therapeutic setting. And so that is one way. Definitely word of mouth, people bring people over, hey, come work over here. And so we've been fortunate enough to have, I think our BHS division is at 119 individuals at this point. And overall, we've been able to, our clinicians stay on average about 3 years, which is good for us. They get licensed, and so sometimes there's not opportunity for growth, but we've been able to maintain and keep people. For those that have been able to obtain licensure, or others, they've been able to advance within the agency. We have 38 programs, so there's a lot of opportunities for growth, which is also a good incentive for our clinicians.
I'll just add two kind of key programs that have really helped too. We partner with USC, so we house like MSW interns from USC, and then USC offers a stipend if they stay with us for 2 years in partnership with us. And so that has really helped with our interns, like getting ones that are good and quality so that they can apply for the stipend program. And then it gives them incentive to then be hired for, I think it's a 2-year minimum requirement. And then our executive management developed a education program that has really helped, where our case managers, if you came in bachelor's level, you provided services for a long time within our agency, you can then apply for your like MSW or MFT program, and we'll pay you full-time salary while you complete your internship hours. And so they can do their internship with Shields. And that has those employees that went through that program stay for a very long time. So we've been fortunate to have that kind of built in place.
Yeah, thank
I
you.
hope that answered everything. Okay.
Perfect.
All right, we'll keep rolling then. With this one, so Danielle kind of already mentioned, but our expansion within the Family First Prevention Services Act, we really were able to just expand our FFT and MST services. And so we already had existing teams of FFT and MST, but within this act, we were able to apply for additional clinicians. Um, and so with the FFPSA, they really highlighted community-based organizations. And I love that they did that because we're already there and we're already in the community. And for Shields, we've been in this community since 91. And so we're trusted, we're already a resource that families use. And so with this additional funding, we can use existing relationships and just kind of expand on those and broaden our reach.
For sure. And then with our MST, FFT expansion, so even though we've been in the community, a huge thing for us is still to continuously not say, hey, we know everything. We don't. And so doing that continuous needs assessment to ensure that we are meeting the needs of our participant. And then, of course, before agreeing to participate in this expansion, ensuring that we had a sustainability plan, because we do not want to do what historically has been done to our community, is that when individuals see a grant, they go for it, they come in and provide amazing services for a year, that funding leaves, and then that program and those services have to leave. So ensuring that we could continuously provide the supports that we're building in under FFPSA, if and those funding should somehow, some way not be available any longer. We can go on to the next one. With our structure, so ensuring that we have those relationships, those collaborative partnerships set up to make sure that we are meeting the needs of those within the community that can benefit from those preventative services. So we have weekly meetings under DMH, with DMH, to ensure that our systems, look, y'all, we're communicating. We're so excited about this, not working in silos, but communicating with one another to ensure that, again, quality preventative services are in place and that our communities are supported overall. And then just to go into just like our schools and integration and what we've done there, just to really highlight what FFPSA is doing and how we're still addressing those disproportionalities that we're seeing within the school system. We've identified 2 of our schools in the community that have over 10% of African-American student body. So we are partnering with Markham and UCLA Horace Mann School. And so what we've been able to do there, they've been amazing, giving us whole classrooms so our staff can be on site all day, every day, working in partnership as part of the school staff. So we've been able to place our FFT and MST teams on site at the school to not just provide supports to that individual student, but to provide supports to those families that really need just like an additional bump of support to ensure that their students are successful and that their entire family is successful in meeting their outcomes or their identified family goals overall. We've been able to provide those caregiver workshops to ensure that caregivers are aware of their rights, they're aware of all the changes within the system, so they can hold us accountable as a system to ensure that they're receiving everything that they should be receiving, and call us out when they're not receiving those supports and that they're required to receive. Those student workshops, really just, again, that education, making sure that their voice is heard, they understand the system, and that we're providing them with the skills that they need to be successful, enhancing those skills too that are there. And then again, that trust piece there with clinicians, if they're on site, they see what you like to eat for lunch, they see how you dress, they know what car you drive, they know how you say good morning, what music you listen to. It really culturally just builds that trust for our students. They're like, oh, that's such and such. I've been an auntie, a godmom, whatever else you want to call me, an annoying auntie that gets on their nerves and knows all their business. I've been everything in the book, but that relationship and being there and that exposure to the students and the family really supports with building that trust and overall, like, okay, I do need help, and I feel comfortable saying that to you because I trust you. I know you. I've been able to see you. I've been exposed to not just you, but to your agency. I'm going to jump in and do services because I know I can ask for help and not face the consequence of child welfare unnecessarily or criminal justice unnecessarily. So it's really about incorporating that the cultural aspects that we've seen support our families with overall engagement and sustainment in services.
All right. So just putting it all together, so the FFPSA really did allow us to just expand our services so that we can reduce barriers to care. The thing that I love about schools and I'm so passionate about schools is because you get access to students that would never walk through a clinic's door. And so by building that relationship and making our clinicians available no matter what, a student that might not have received services is more open to receiving services. And so this just allowed us to expand that more. We do expect our clinicians to be out on the blacktop with students, to be at recess with students, and to be at parent meetings so that they're just available to the community. And this just allowed that to increase. So right now we are one of the community pathways for DMH. And so as DCFS is referring or a family walks in and needs support, they can refer directly to our MST or FFT teams. We also have the Community Cultural Broker Program. It's a pilot right now for prevention services and plans of safe care. So if we have mothers that have a substance use disorder and are currently pregnant, we can provide a plan of safe care so that we can ensure the hospital staff are aware that the mom already has a plan in place to ensure the safety of her child and to decrease removal right at the hospital in labor and delivery. Preventative legal services pilot, and then we participate in the pilot for Welcome Baby, and then we are the original members of LA's Thriving Families program. Our CEO, who's in the room right now, is also a tri-chair of the state's FFPSA Advisory Committee and co-chair of the PEI Committee for the California Child Welfare Council. And so we really have had that roots in prevention for our entire existence, and this just allowed us to really expand that. So we also, with that, we just say thank you,
Yeah.
and then, oh.
No, I was just gonna say, we have a couple of questions in
Yeah.
the chat. Kavan says, are your clinicians co-located in the schools?
Yes.
Yeah.
They're
Yeah.
co-located in the schools, but expected if the family and or student prefers to do within the community or within where they reside, then they're expected to do services wherever the participant is most comfortable.
Mhm.
And Orocio asks, what is Welcome Baby?
Welcome Baby is one of our programs focusing on that 0 to 5 age range. And so they really go in, it's a light touch, like case management support, where they do like 4 in-home visits to really support those more at-risk mothers who are pregnant and just have children to ensure that they're linked to services. It's really like that light touch. And then we link them to our more intensive program to support with ongoing attachment and any other family related needs that come up.
Yeah. They're housed in the hospitals too.
Mhm.
So the hospitals refer directly to them, and then somebody will do an intake and then provide support services in the home. So many families get the benefit of a doula, and then also their first visit by a registered nurse in the home. So once they take baby home, then they'll get a registered nurse coming to the home.
Yeah. Again, the goal is to reduce that child welfare involvement. And so unfortunately, our systems have a way of tagging at-risk families or families that have had past history of child welfare involvement. And so most often a beautiful moment of delivering their child is met with having a social worker approach their door. And so it's really to help ensure, like Christina said, that this family's okay, they're in care, they have preventative wraparound supports, no need for child welfare involvement. If there's a need, we will work collectively with the family included in that process to then involve child welfare. But it's really the goal is to prevent that involvement.
Does anybody have any other questions? Oh, here we have Welcome Baby is a great program. I had the opportunity to have received that service with my firstborn. Having the nurse in my home within the first week my child was born was amazing.
That's
awesome.
awesome.
Thank you.
Thank
I
you
love
for
nurses.
sharing.
Thanks for sharing. Yeah, that's awesome.
Yes.
Serena.
Yeah, I'm curious. I think I remember earlier you mentioned that you give presentations to educators about the community that they are serving. So I was curious how similar it is to some of the data you shared with us or what you do differently. I work within the education system and I could see that being something I could implement. So I was curious any insights you have to share on how you approach.
Beautiful. No, really the same way. We come from a lens of this is not to blame anyone. We all have faults. Our systems have faults. And so it's really just about identifying the systems, the faults within the systems, and let's work together to create a plan, right? Our educators are with our kiddos. It's usually 1 to 35 for 8 hours a day. And so really coming in with the lens of, we get it. It's difficult. It's tough. And it's really about the lack of resources or the lack of knowledge of resources available within the community. So we present the data, but again, we definitely provide that lens of we're here to support and to be a support and work collectively with one another. So it's really a collaborative approach for us. Also, we bring food. So that always helps. We bring food and we definitely bring in some resources. So whether that's, fidget toys, coloring books for the teachers so they can have something where they can de-escalate within, their own setting, their lunchtime. So we really bring in some tangible resources that are from the educator's perspective, to really support with classroom management, setting up those behavioral charts and how to do them, how to welcome a student in who was just detained and returned home. Those are things that we're not necessarily taught. And so just really taking the time to teach those things.
Any other questions? I just had one because I took copious notes. The Cal Hope program, I just learned about that. And for those of us in rural communities, it's a great resource for behavioral health services. Could you talk a little bit about Cal Hope?
Sure. So our Cal Hope is like a mighty two-man team right now. And so really those things in that like our DMH contract or our substance use contract doesn't necessarily allow us to bill for because we all have to sustain, right? That's just the reality of agencies. However, Cal Hope really is like that navigation piece. So if families need additional supports, an individual within the community, they provide outreach events, they go to the home, they're linked to individuals, and it's their job to really find the resources that a family may need and or benefit from and present that to the family. They support with those warm handoffs. So not just like, hey, here's a number you can call. The navigator's job is really, they need to call, they need to make sure that an actual person answers the phone, and then they provide that support to the family. So yes, I agree. It is a huge benefit. It really covers all of those ancillary pro bono activities that are needed to engage families. They really provide that support. Yeah.
Thank you. And you got to wonder, Innocenta, she worked at Shields for Families prior to coming to LA County. So that's wonderful. And she says she knows firsthand the strong collaboration with the community and the positive outcome. And she's so happy to see the expansion of services over the last 30 years. Keep up the great work.
Yeah.
It is great.
Thank you.
Hi.